I'm Dr. Henry Black, a clinical professor of internal medicine at the New York University School of Medicine in the Center for the Prevention of Cardiovascular Disease and president of the American Society of Hypertension. 2008 and 2007 have shown us a lot of new clinical trials which have involved either primary prevention or secondary prevention. There are two studies in particular that have happened this year that I would like to highlight. The first is about secondary prevention, published surprisingly enough, in my opinion now, about a year and a half ago. That's the COURAGE trial. That's still so fresh in my mind that I thought it was just yesterday. The COURAGE trial looked at whether or not percutaneous stent placement compared to aggressive medical therapy was going to have equal outcomes. This was about 2,200 patients, and to many people's surprise, maybe not to mine as a preventive cardiologist, aggressive management of risk factors did just as well as intervention. This means we have to teach our doctors, ourselves, our trainees, what it means to do aggressive primary prevention. How do you manage lipids? How do you manage blood pressure? What do you do about glucose intolerance and diabetes? What do you do about weight? These are very important things. And if the COURAGE results are going to be impactful on the general population, we have to pay attention to this and know how to do it. The more recent trial, published and presented just in November of 2008, is JUPITER. JUPITER, as you may recall, had the hypothesis that selecting out so-called low-risk individuals by current standards, that is, people whose LDL cholesterol was less than 130 milligrams percent, would benefit from treatment if they also had an elevated C-reactive protein, defined as 2 milligrams per liter. Now, CRP and hsCRP in particular have been around for decades. CRP is a good marker of inflammation. In fact, if you have periodontal disease, for example, or rheumatoid arthritis, your CRP goes up as a result of the inflammation. And this can be subtle. You may not realize that somebody needs some dental work. And if you see an elevated CRP and you don't really know why that is, that's a good place to start looking. Well, what the group led by Paul Ritger at the Brigham and Women's Hospital have hypothesized that if you selected out people with normal cholesterols by our current definitions, ones that we don't treat, that is, people who were previously healthy, have not had events, do not necessarily have other risk factors, and treated them based on their CRP levels with a statin, in this case they used rosuvastatin at 20 milligrams, that you would prevent events. This was quite controversial, and I'm very pleased to say we have a definitive result, in my opinion. The study was large. About 8,900 people received rosuvastatin and 8,900 received a matched placebo. About 38% of the people in this trial were women, and men had to be over 50, women had to be over 60 to be entered into the study. They couldn't have had events. They couldn't have had hypertension that was being treated. They had metabolic syndrome. In fact, that was pretty common, about 41%. But they didn't meet the criteria for lipid therapy as we currently use. Well, this study was stopped after 1.9 years instead of the planned 5 years, with definitive results. The primary endpoint, which was a companion endpoint, a comparison of stroke and heart attack and cardiovascular disease and cardiovascular mortality and percutaneous or surgical intervention, plus mortality, was definitively reduced, in fact reduced by about 46%. The initial LDL level was only 108 milligrams percent. Very, very few people would recommend therapy, and the average CRP level was 2 or more, which is modestly elevated, not terribly high. They also looked at all the subgroups, since this was a large study, and the benefit was seen in men and in women and in the older groups and the younger groups, and people who had metabolic syndrome, people who didn't, and so on. So this benefit accrued across the board. The only downside, it turned out, was that there was more physician-diagnosed diabetes, 270 cases versus 216. Everything else benefited the people who got rosuvastatin. It's a little unclear. Hemoglobin A1C went up modestly as well, so there may be something we have to look at here. but certainly outcomes were clearly and definitively improved. So what does this study mean for stratification, and what does it mean for therapy? Well, we like to look at a so-called number needed to treat, which is the reciprocal of the absolute difference between Group A and Group B. Turned out that you needed to treat 95 people for 1 year with 20 milligrams of rosuvastatin to prevent one event. You only had to treat 44 for 4 years to prevent an event. That's extremely low number needed to treat and extremely cost-effective therapy. So right now I think that you could make a case, or I could make a case, that your so-called healthy people should get an HSCRP as part of their initial screen. It's a stable test, it's not expensive to do, and it really helps stratify healthy people right now. One thing that was missing, of course, in this study is they didn't do people with any CRP, including ones even lower than that, as opposed to any cholesterol level. That would have been helpful. What does it tell us about statin therapy? Is there something magical about rosuvastatin? Don't know. This gets to the class effect in therapy. My own opinion about this is some things that would appear to be a class effect, but right now we know how much to give and what happens. The outcomes, it turns out, there was no more myopathy in the group that got rosuvastatin. There was only one non-fatal rhabdomyolysis, which was in a 90-year-old who also had trauma. So this was an extremely safe therapy. And cholesterol was lowered to 55 on average, LDL cholesterol to 55 milligrams percent. That's something we used to worry about. We're going too far down. It's not going to be good. I think that's been put to rest as well. So Courage has told us that we have to know how to treat people who need secondary prevention, and Jupiter has helped us sort out who's going to benefit. We certainly do much better if we direct our therapy at the people who need it. Thank you very much for your attention.